Hi, everyone. We've had to move locations and we are going to get started on GYN. I don't know if you saw Elizabeth sticking her tongue out at you, but here we go. We're going to start with GYN and we'll get Elizabeth going. It's a little quieter here. There's construction going on in the School of Nursing, and you've obviously heard it in the last one.
All right. It's warmer in here, too. Hi, guys. Oh, I was just photobombing. You know, I'm a little on the wild side, so gotta keep things as light as we can during all this. We have an issue with she didn't say this, but the PowerPoints aren't gonna be, they're gonna be separate. So you're gonna have to figure out for this and dental and oral. So you're gonna have to figure out how to pull up the PowerPoints as we're listening to the audio. So we're gonna start with GYN disorders in children. And one of the big parts of your chapter is pregnancy. Well, you might diagnose pregnancy, but unless you're in a women's health specialty area, you're not going to deal a whole lot with pregnancy, and you should know all about that. And I'm not going to talk about that. And we're not going to talk about periods, and as far as from the perspective of menses and all that. You all know all of that already, or you should. If you don't, then you need to go way back. So we're going to talk about some very specific gynecological conditions that you may see commonly in a pediatric environment. I gotta move this up. I gotta move myself up into the corner so I can see. All right. The first thing we're going to start with is some things you may see. We talked about, if you've already watched the genitourinary, we've talked a lot about genitourinary issues with males more so than females. But from the GYN perspective, I saved this to do with GYN because labial adhesions in a female is more GYN related versus urologic related. This is a fusion of the labia minora, and it can appear to cover the vaginal opening and of course the urethral opening. Sometimes if you're concerned about a UTI, sometimes you can find labia. So looking at genitalia is imperative from infancy through adolescence. They don't like it when they get older, but it's really important at least to do a look, okay? So labial adhesions are usually found in infants and younger girls, and we see this actually quite frequently. Again, it's the most preceding factor to asymptomatic vulvovaginitis, and usually anywhere from 3 months to 6 years. And it's kind of like penile adhesions, where the foreskin sticks around the corona after circumcision. With girls, the labia lay right next to each other, and they just have a tendency to fuse. And you can see that line most of the time where they have come together. So, so if you look if you've got version or edition 6, and this is the book that I'm still referencing on page 460 or 964, table 36.3, it talks about treatment for labial adhesions. So sometimes urinary and vaginal drainage can be impaired. Sometimes it's not, but we need to make sure that there's not complete closure. So it isn't. So we're going to use an estrogen-based 1% cream like Premarin or Estrace, and believe it, those are very expensive. And it just takes a pea-sized amount, and you're going to put it on with a cotton-tipped applicator twice a day for 2 weeks at a time. Okay, and then you're going to do it down to once, like at bedtime, for 2 weeks if needed. And sometimes you have to take a break if it did not open up completely or partially. If only partially, you need to take a break from it and then redo it. It's important once it's open, just like with penile adhesions. You've got to keep it lubricated to keep from sticking together again. So it's really important to tell parents that, because this may not go away really easy. So we've got to keep a check on it. This can be missed if you're not doing genital checks. And I have picked up labial adhesions that were not picked up by another provider. So that's really important. But usually, sometimes they will rip it open. The provider will rip it open. I don't ever recommend doing that. If you can't seem, even with treatment, to get them to get it to open up, then usually we refer to urology, peds urology, and again, sometimes they will go ahead and rip it open, but that's them to do and not me. I'm not gonna do that. Whew. But it's your choice. So another common GYN problem, and this is not only in adult women, but this starts in little ones and goes all the way up, is vulvovaginitis. And this is inflammation of the vulval urethral vault, usually with discharge, sometimes with not always discharge in children. A lot of times poor hygiene, or especially if you've got a kid in diapers, it's just because they wear a diaper and there's poop and there's pee. And sometimes antibiotics, as we know, can cause it. Trauma, of course, if they've got any kind of diaper rash, harsh soaps, bubble baths. We've had that discussion already. If you've already seen genitourinary, little girls especially don't need to be in a bubble bath. Tight-fitting clothes or nylon underclothing are they hold in the heat, they hold in the moisture, and that is just a hotbed for yeast to grow. And of course, diapers. Some of the symptoms may be itching, pain. You're going to see maybe some redness, maybe some issues with pain when they pee, or bedwetting. That can be an issue. And then sometimes perianal itching, just from the yeast. So on table 36.4, usually candidiasis requires an antifungal. Usually we use an azole like nystatin. Topical or oral. Sometimes if topical is not working, then we have to do diflucan or fluconazole orally. And if you do fluconazole orally, it's going to be 6 mg per kg on day 1, and then 3 mg per kg per day for 5 to 6 more days. It is not a 1 or 2 doses and done. It's got to be for about a week if you want to get rid of it. So this is what we do. This is what I do because that's how I've been taught. And the docs that I work with, this is what they do. So, and I actually use fluconazole orally more than you know, especially now statin doesn't always get it. Sometimes I'll use clotrimazole. When I was in Eastern Kentucky working, clotrimazole became my drug of choice because nystatin just never did seem to be taking care of anything, whereas clotrimazole did a much better job. So, but here it's still nystatin first line, and sometimes I'll change it to clotrimazole. Sometimes if it's really bad, I'll start with clotrimazole. So anyway, vulvovaginitis, just one of those things that happen, more so girls than boys, but yeast can happen, especially in the diaper, if they're still in diapers. Menstrual disorders. Mittelschmerz, you all know what that is. It's that ovulation pain that occurs between mid-cycle. Some kids that don't understand that can be an issue can think that they're having something's going on. Parents will bring them in. We think that they get this pain because of it's the follicle rupture and then fluid irritation of the peritoneum. It can range from dull to severe and crampy, and it can last up to 3 days. And it usually occurs at the same time in the cycle. So history is going to be really, really, really important. So there's not a whole lot you can do about that. You need to reassure them that this is normal and that they need to treat it with ibuprofen or Tylenol if they're allergic, and maybe some heat in the area, and that it's just going to be. They don't like to hear that, but that's unfortunately one of the things. Dysmenorrhea, we're seeing more and more issues with dysmenorrhea, and menorrhagia and metorrhagia in adolescents especially. Painful dysmenorrhea, of course, is painful menses with cramping. If it's primary dysmenorrhea, if there's been no pelvic pathological condition like an STD or anything else, or secondary if they've got like PID or something like that going on. It's usually in primary dysmenorrhea, it's caused by increased production of the prostaglandins, which is brought about by falling levels of progesterone. So what will help keep levels of progesterone up? We'll talk about that in a minute. In kids, well, menstrual disorders in general, for women is the #1 cause for work and school absence. So the gentlemen in our class may not understand that, but several of the women, if you've had issues with periods or painful periods, then they can be debilitating. So that makes sense. So what are we going to do? So prostaglandin, if it's a prostaglandin issue in primary dysmenorrhea, ibuprofen or naproxen are your drugs of choice because they're prostaglandin inhibitors. So with our adolescents, you can do 600 every 6 hours or 800 every 8 hours, as long as they don't consume more than 2,400 milligrams in 24 hours. And you see that with naproxen, they can do 500 every 6 to 12, as long as they don't have more than 1,250 in a 24-hour period. Now, another help, and this is where I was going, what else can we do to help progesterone from falling? And that's oral contraceptive pills or oral contraceptive therapy. And this is used widely. We try really hard not to put a girl on the pill or on a contraceptive progesterone estrogen combo at a very early age. We want to make sure that their periods have been well established, because as you all should know, girls don't necessarily start their periods and have a regular consistent period. For the first couple of years, it can be very inconsistent. So we want to make sure that they've gotten a good menstrual pattern established. Also, it can affect height, vertical height and growth. We want to make sure that they're fairly well developed, and before we put them on the pill. And we've had them as early as 12. I don't like to do that. I don't feel comfortable doing that. But the docs that I work with will start them on the pill for period issues. Now, if we've got a secondary dysmenorrhea, you've got to treat the root cause. And this usually includes a full workup by GYN, but I will tell you that I've had my share of girls with period issues that ended up having an STD. And I don't mind checking for STDs. I don't do necessarily swabs. I can if they'll let me, but it becomes very, I'm not as practiced with that. It's not my expertise. I will test for chlamydia, gonorrhea, and I've had lots of gonorrhea. I've had lots of chlamydia. I've had a patient that's had trick twice, and we have sit down and have long talks, and I'm not sure that ever helped any. But so, and then there's some other issues that can cause. Before I go on to the next slide, which is about something else, one of the other things that can cause horrible periods, and I don't talk about this in my slides, and I'm not sure they talk about it in your book much, and that is polycystic ovarian syndrome, PCOS. When I was worked in Eastern Kentucky, I had a huge population of young women that had PCOS. They had the elevated testosterone and the abnormal, I think it's 25 OH. Anyway, that's bad. I should know more about this if I'm going to tell you about it. But anyway, and I have it written down. I have a book where it's like, okay, if I'm looking for somebody with PCOS, I'm going to do this workup. And included, of course, a CBC full lipid panel. Of course, you looked for hirsutism with they had sideburns, not necessarily, maybe dark hair and a lot of hair on their upper lip. They had what I call the apple physique, bigger in the top, smaller at the bottom. And they also had lots of menstrual issues, and they had insulin resistance as well. So that's pretty classic PCOS. And usually metformin was one of the drugs. Again, this is not necessarily, this is a sidebar, but PCOS should be in your differential. If you've got a person that may be having those kinds of characteristics, you should do that full workup to include all that stuff, as well as your estradiol, your testosterone, your follicle stimulating hormone, and LH, and all that stuff that you're doing from a hormone perspective. So you need to look at the lipid panel and the 25 hydroxy, I can't remember. Anyway, you need to look at all of that. And I'm sure that is somewhere in your book and in your lectures somewhere else. But keep, especially in your adolescents, keep PCOS as part of your differential. Okay. So let's move on to breast issues. Now, you've got kids, both male and female, that have breast issues. Breast pain is very common, but severe breast pain in any lumps or masses must be fully evaluated. As girls develop, they may have one breast that develops faster than the other one. So you've got to talk them down off the cliff with that, or they're having pain, or they're having lumps, and there may be a family history of breast cancer. There's no family history of breast cancer, but mama's freaking out thinking that her adolescent has breast cancer. So this is really important. So you have to approach it very calm and factually, and then assess it. Also, infants can also have engorged areolas at birth. So you need to check that. And they're usually due to mom's hormone influence. And this is even in males. So if moms ask you about it, you just say, oh, that's just leftover hormones. This should resolve on its own. And most of the time it does. But you want to keep a